on the 29th. Yeah, January 29th. And we have our introduction to AHS. Secretary with us, and so welcome.
Nice to be back. For the record, I'm Jenny Samuelson, the Secretary for the Agency of Human Services. And it's a privilege to be here with you today to do what will be a very broad overview of the agency and an orientation. We'll give you a whole review of the entire agency, and then we can focus in a little bit more on the healthcare related pieces. But I think it's important that those two are, the health part and the human services, are so interconnected to make sure everyone has a level set. With me today are several of my colleagues. I have our Deputy Secretary, Kristen McClure, with us, and our Medicaid Director, Monica Ogilby, and our Policy Director. It will be in the phone a friend mode if necessary, Brendan Atwood. So just a brief overview. The mission of the agency is to improve the condition and well-being of Vermonters. The vision is that Vermont will be a place where people have the opportunity to thrive in an inclusive, equitable, and resilient community. I think it's worth noting the breadth of that mission is across both health and human services. As an agency, as a grounding, the Agency of Human Services is made up of 6 departments to effectively achieve this mission and vision. Those departments are together within one agency so that we can effectively deliver a wide range of human services, dividing the responsibilities into distinct roles and responsibilities allows us to dig deep in areas like mental health, in areas like how we administer our Medicaid program. But it also gives us with that specialization, we also have the opportunity to collaborate across programs, because what we recognize and across departments is that for most of the community, families and individuals that we serve, they don't fall neatly into one bucket, even healthcare and human services. And so what we've really been driving towards, and what we drive towards every day, is that cross-cutting collaboration to really impact the interconnectedness of the issues that are facing the communities, individuals, and families that we serve. In addition to that, because we are one agency, we are effectively able to manage complex cases. So those cases that for families and individuals who may cross departments and departmental boundaries, as well as to effectively manage and maximize federal funds. And an example of that is our Medicaid program. Often people think only of the Department of Vermont Health Access, but our Medicaid program is actually across the majority of the agencies, with a specific focus of the funding at the Department for Mental Health, Disabilities and Aging and Independent Living, who administer key components of our Medicaid program, and the Department for Vermont Health Access. We also are able to use the Medicaid funds in all of the other departments, including the Department of Corrections. And so we are among many states who have a comprehensive Agency of Human Services, so we can achieve those goals, to specialize, to collaborate, and to effectively deliver services. So the agency is made up of the Secretary's office, which includes healthcare reform, oversight of the full Medicaid program, because as I said, it doesn't live in just one department, but lives across all of the departments within the agency, the Blueprint for Health, and the Health Information Exchange. In addition to that, we have 6 departments. We've got the Department for Public Health, Department for Disabilities, Aging and Independent Living, the Department for Vermont Health Access, Mental Health. Unique to Vermont is corrections, and I think that represents the values that we have in Vermont to ensure that we are addressing the root causes and really moving towards rehabilitation, and the Department for Children and Families. So within the Secretary's office, the leadership team, and I'm going to introduce many of them today who are here so that you know who to go to. Your first line of contact will often be Brendan, who is our policy director. But at the agency kind of overseeing those programs, you have myself, My counterparts, our Deputy Secretary, Kristen McClure, Monica Ogilvy, Brendan Kraus, who I think you've already been introduced, is our our Director for Healthcare Reform, and Rich Donahue, who we were in on BAA, who is our Chief Financial Officer. I want to make sure to do those introductions because all of us are open to answering any questions that you have about our broader programs. So the Agency of Human Services really is grounded in a core set of values and key approaches to doing our work that I think are important for us to emphasize. For us, transparency, so the willingness to be open and honest about what's working well, what's not working well, and really soliciting feedback from the individuals that we serve and the providers who support our broader programs is important. And I think that transparency, particularly as we're looking at what's not going well and how we improve, is core to our values. And with that comes integrity, making sure that, when something does go wrong, we have the integrity to stand up and own it, as well as own the things that are going right and live by a core set of ethical obligations. Service Vermont, the Agency of Human Services serves a lot of Vermonters. We also serve a lot of providers. And so service is core to the work that we do. But the way that we approach the work is probably one of the most important things. We know that the environment around us is constantly evolving, that we need to evolve the programs that we have to continue to serve Vermonters better and to serve providers better. And so we're constantly looking for innovation, not innovation for innovation's sake, but constantly evaluating and determining what programs are working, where we need to change and enhance programs, what gaps have emerged. For example, with the substance use crisis that we've seen in Vermont, opioids were what we were really addressing 10 years ago. That now has evolved to stimulants and a lot more co-occurrence and co-pharmacy. So that's a place where we can't stop innovation. I'm lucky to have one of the most dedicated staff that I've ever had an opportunity to work with. And that dedication leads to significant collaboration. And I will say, I've been with the agency for almost 20 years, and collaboration was always a catchphrase. I think what the pandemic really did was it drew the agency together to see how they could collaborate more meaningfully, whether that's at the systems level or at the person and the family level. So those are really important to us. Grounded, the Agency of Human Services is the largest agency in state government. Our general fund budget is $1.3 billion. Our overall budget, including federal funds, is over $5 billion. So we are sizable in state government. With that, we have, including temporary employees, we have over 4,000 employees within the Agency of Human Services. And you can see how they're distributed across the agency, with our largest departments being the Department for Children and Families and the Department for Corrections, both about equal in size. And then some of our smaller departments being the Department for Vermont Health Access, Department for Disabilities, Aging and Independent Living, and the Department for Mental Health. So it's important to note that while much of state government is often very centralized, we do a lot of our work at the local level. And so for this, I'm going to hand it over to Deputy Secretary McClure.
Thank you, Secretary. For the record, I'm Kristen McClure, Deputy Secretary, Agency of Human Services. As the Secretary mentioned, one of the unique items for the agency is we do have district offices, 12 district offices in each district, really at the local level. So that's shown on the map here. Another really unique item that we wanted to call out is each one of those districts has a field services director associated with it. There's one field service director covering 2 districts, so that's the color coding here. And they're really a high-level position at the agency to work with the community, work with legislators, work with municipal leaders, and really problem solve some of those larger items across the community. It also, in those district offices, provide a number of services that we've listed here. So I think we can go to the next slide. I think we've reordered them, so we're going to hit a few of the departments that we want to focus on, as well as a few of the departments we want to move through faster. So I'll hand it over to our Medicaid director.
Everybody, for the record, Monica Ogilvy. I'm part of the executive leadership team at the Agency of Human Services, and I'm the state Medicaid director. And for those of you I haven't met, I just wanted to provide a quick snippet on what my role is as state Medicaid director. Our Medicaid program spans all 6 departments of the Agency of Human Services, as the secretary mentioned, and the Agency of Education. And so historically, the state Medicaid director position has been held by a leadership role within the Department of Vermont Health Access. We very intentionally pulled that position out and made it distinct within the secretary's office so that there can be some degree of oversight of all Medicaid program, all policy and all finance across everywhere where Medicaid lives within the state, which has created an incredible opportunity for collaboration and efficiency across our Medicaid program. So that's my little elevator speech. Working on it. So one of the departments that we work really closely with, obviously, is the Department of Mental Health. Their mission is, all my slides got cut off. I won't read their mission. You can see it. But when you think about the Department of Mental Health, they're everywhere. So there's the facilities, the Vermont Psychiatric Care Hospital, but then they're also very much in the community, starting early in the prevention space, all the way to the high acuity needs. Thank you. So some of the initiatives that the Department of Mental Health have been spearheading and really working to improve statewide access are things like 988, mobile crisis, mental health urgent care. And you may have heard of CCBHCs, which stands for
Certified
Certified Community-Based
clinics.
I cannot, that's not it.
No, because there's a B at the end.
Yeah. For the record, Nicole Destasio.
Yeah, it's a certified community-based integrated health center.
There you go.
Thank you. There she is. Thank you so much. Sometimes you need to phone a friend when you're on the spot. And that is an incredibly exciting opportunity where we're seeing the real significant and intentional integration of mental health services in our substance use treatment space, including a primary care approach. So really thinking about whole person care, and we're working diligently to advance this throughout the state. So when you think of Department of Mental Health, it's everything from community-based in the schools and providing some support at the higher level of need. Slide, please. Okay. Next is the Department of Vermont Health Access. Their mission is to improve Vermont's health and well-being by providing them with access to high-quality, cost-effective healthcare. So the Department of Vermont Health Access, or as we finally refer to them as DVHA, is really the work engine of the Medicaid program. So DVHA is where a lot of our Medicaid functions and operations sit and live. So when you think of a typical health insurance company, things like enrolling providers, enrolling members, paying claims, things like fraud, waste, and abuse, quality monitoring, et cetera. They provide all of those basic functions for our Medicaid program. Additionally, this is where Vermont Health Connect lives, where Vermonters can sign up for health programs. Next slide. The Vermont Department of Health, their mission is also cut off here. I'll let you read it for yourselves. But what I will say about the Vermont Department of Health is that this is where we really see the department touch every age, every stage of life. So the Department of Health provides services such as newborn screenings for every newborn born in Vermont. So every child, every newborn is screened for over 30 inborn genetic conditions, including hearing. And then we also, everything to children and youth with special health needs, environmental health, epidemiology, where we saw them have an incredibly critical presence during the COVID pandemic. And they also have a very strong presence in all of our offices of local health that we talked about before. So there's nurses in every office of local health throughout our districts in the state of Vermont. They're there to provide screenings, support through our Women, Infant, and Children's program, immunizations for individuals that are underinsured or uninsured. So the public facing element of the health department is ever present within our district offices. We're very grateful for that effort. Next slide. And the Department of Disabilities, Aging and Independent Living. I think, did they come in to do an overview yet for you?
No, we typically don't have Dale come in.
Okay. So this department has an incredibly broad book of business. So Dale covers everything from things like nursing homes or choices for care. They're largely funded through Medicaid. They also provide services and supports through our designated agency network for individuals that have intellectual disabilities, developmental disabilities, both in the schools and in the community through home and community-based services.
A major intersect, I'm going to interject here, and a major intersect between the Health and Human Services committees here at Dale is the skilled nursing facilities. And the reason I bring that up is that whether the jurisdiction for skilled nursing facility sits in one or the other, the impact in the flow in our healthcare system is significantly predicated on the success of this department, both to provide home and community-based services. And what we've seen in the last couple of years is that when we saw a significant reduction in the total number of the skilled nursing home beds, Dale has been really working to bring that up. And the impact on the healthcare system had been when that system wasn't working at its maximum, and it's just now coming up to pre-pandemic levels, as we talked about in the BAA. What we saw is we're getting back to pre-pandemic usage of that. What that has meant is that we've had significant numbers of individuals boarding in hospitals. And the impact, as an example there, has been that Rutland Regional Medical Center wasn't able to have their ICU operate as an ICU because they've been using it to do med surge. And so having the skilled nursing facilities and some of the systems that Dale runs running well has had and the same thing with the Department for Mental Health, has had a significant impact in our broader systems. And what we are seeing is them come back online. We're also seeing some of the sustainability work that we've done with things like bringing eye care, which is a specialized skilled nursing facility for those with higher acuity needs, many of whom have been in hospitals for more than 400 days. Can you imagine that? Living in a hospital for more than a year. And so while much of this committee doesn't work with Dale, it's really important to understand some of the systems that Dale has and the impact that they have on the broader healthcare landscape that you are working with.
Thank you. Excellent.
Okay, so this is the Department for Children and Families. I'll take you through this department and our last department as well. As the secretary mentioned early on, this is one of the largest departments at the agency. It also has a really broad book of business and is very diverse. So within, also known as DCF, the Department for Children and Families, it has 6 divisions, and I'll take you through a high level of them. One of them is the Family Services Division, also known as FSD. So this works directly with children, directly with families. So when you hear of a child in DCF custody, it is this division that's working with that, or working with foster families, foster parents, adoption agencies. It's really this division that does that work. Another division is the Child Development Division, also known as CDD. And they work with community partners to provide childcare and child development, such as after-school programs. There are 2 other divisions I'm going to take you through. They tend to run a little under the radar. One is the Office of Child Support. So they work on parentage of child and parent, and to ensure that child payments are being made appropriately. The other division that kind of runs under the radar is the Disability Determination Services, also known as DDS. So they really determine medical eligibility for disabilities based on federal rules and regulations. There are 2 other divisions that are probably more well-known. One of them is the Office of Economic Opportunity, thank you, also known as OEO. And they provide grants to the community. So one of the items you're probably more familiar with is some of the shelter work that goes in the community. And that's really from this office, this division. OEO, Office of Economic Opportunity. And the last one, the sixth one within the Department for Children and Families is ESD, the Office of Economic Services Division. So much like OEO provides money directly to community partners, this division provides financial assistance to Vermonters, so individuals or families. So they provide financial assistance, food assistance, fuel assistance, or temporary housing assistance. So like I said, a really broad book of business for this department. And with that, we'll go to our last department, which is the Department of Corrections. We did think, as the secretary said, it's really important to share the overview of all our departments because they do intersect together. So Department of Corrections does work really closely with Department of Mental Health, Department of Vermont Health Access, our VDH, Department of Health. So overall, from a facility standpoint, Department of Corrections has 6 facilities, 5 for the men, 1 for the women, and 1 out of state. Also, from a facilities perspective, I talked about the district offices earlier. There are 12 parole and probation offices, and that's within each district. In addition to facilities, there is the Vermont Correctional Academy, and they provide standard training for all the correctional officers before being deployed. But one of the really unique items we wanted to mention from the Department of Corrections is it's a unified system. So meaning they really do end-to-end services. It could start with pretrial supervision, court ordered. So if a court orders supervision before trial starts, they would engage in that space. They also work with the detainee population. So people that have not yet been sentenced, the detainees. They also work with the sentenced population, so people who have received a sentence that are incarcerated. And lastly, they work with a community supervision, so people that are out on parole or probation are also within their scope for supervision. So that provides an overview of all the departments within the agency, and we'll hand it back over to the secretary.
One of the things I wanted to point out, and the reason why I think it's important for us to have a conversation about the Department of Corrections, is the Department of Corrections actually is a significant healthcare provider. They do contract with an outside healthcare provider to provide those services, but much of their care also happens in local community hospitals and in other facilities. And so this is a department where you heard the Deputy Secretary discuss the level of collaboration. An example in this budget year is the Division of Substance Use at Department of Health has been working for years to put medication-assisted therapy for those who have opioid use disorder into our correctional facilities, and to make sure that individuals can continue to get methadone on an outpatient basis if they are incarcerated through our outpatient programs with community providers. What you saw in the budget this year was an introduction to have actual substance use treatment provided in our facilities, which takes us that one step further to have that residential substance use treatment and not just stabilization, which is what our medications are. And so there's a lot of crossover. What you have seen recently is our Medicaid program is now able to intersect with our Department of Corrections by providing transitional supports and healthcare services in our correctional facilities before someone is released to help create that continuum from incarceration back to their healthcare provider in the community. And many of us think of our correctional facilities, we think of it in an age-old standpoint where individuals are staying in our correctional facilities for long periods of time. That's not the case. Many of the folks that are coming into our correctional facilities are there for very short periods of time. And it's an opportunity to really have an impact on their health and then make sure they re-enter our healthcare and human services systems, really with wraparound services to help prevent recidivism.
Tucker?
I've got a few questions.
Okay, I have a question too, but keep going.
First one is what you're just talking about. How is that working now in terms of the judicial system? Has that been straightened out?
Representative, give me a little bit more information. How is what not?
Judge, if a judge gives an order
Mhm.
sometimes the order takes place the next day.
Mhm.
And in order to have that transition from the correctional center outside, how is that working now?
Let me tell you, historically, and then I'm going to have Monica give a little bit more of an overview on a new program that we were authorized in our most recent Medicaid 1115 waiver. Historically, particularly for those individuals who are complex, those included individuals who are on medication-assisted treatment, Hep C, we've used programs like our Vermont Chronic Care Initiative to ensure that if someone is in a facility, that we are meeting with them as soon as we have a sense that they're going to be discharged and they're on that treatment, to make sure that they're connected with a community provider. We're able to do that more systematically now because in our last 1115 waiver, and that's just to bring those who are less familiar with it, the 1115 waiver is our agreement with the Centers for Medicaid and Medicare on how we're going to administer our Medicaid program in Vermont, allowing us to do things then be more flexible than other states are. So in our most recent 1115 waiver, we were able to get authorization to begin to work almost immediately with someone if we knew that they were going to be in for a short period of time, or if they've been in for a long period of time and they know they're going to be discharged, to work with them up front to make sure that we're making those connections before they leave. And I wonder if you can talk about the 1115 waiver.
Yeah, so I think what the secretary is talking about is our authority to use Medicaid for individuals that are re-entering. So they call it the re-entry waiver, re-entering into the community. And as far as 90 days into advance that we're anticipating they re-enter into the community, they're connected with a case manager to help ensure that they have access to housing, food, healthcare, treatment for any chronic conditions. Because as you can imagine, re-entering, especially if having been incarcerated for a while, the logistics of updating paperwork and making sure you have an active form of identification. Those little types of things that are so critical in order to access services are the things that fall through the cracks, and it doesn't take long for people to really feel alone and overwhelmed by what they've got to do. And so re-entering in and of itself is really challenging. And so this is a space for somebody to proactively, in advance of leaving incarceration, have a trusted support service network to make sure that they've got all of those things to set them up for success upon re-entering their community.
So that's in place now.
It doesn't actually take in, we just got authority to do it, permission from the federal government. And so we're really hoping that we'll see this take shape more in 2026, next year.
And so,
Takes a lot of time.
to back up, we've been doing it with success with the Vermont Chronic Care Initiative, again, around a lot of the specific populations that we know have very complex health and psychosocial needs. And that because of that gave us the basis and the foundation to expand that in this way in 2026.
Okay, so my question is simple. Are those people that are coming out of the prison, in terms of their health care, are they being taken care of? Because I know that they weren't before.
We've made a lot of progress in that. I can't say every single person has every single need met, because as you just identified, for those folks who come in and for everyone else, if they come in and live with us for a very short period of time, we get their health care delivered internally, but they go to the courts and they're out and we don't know they're going to be. And so we have done a lot to make sure that the correction system of care uses, this is going to sound like jargon, but the community, the standard for community health care. Essentially what that means is that previously individuals were provided with care based on what we thought folks needed in corrections. That's a national standard. Vermont put that to bed a long time ago. And our goal is to provide people with the care that every Vermonter gets when they enter into corrections. And that's why you're seeing us offer the residential, hope to be able to offer a residential treatment program inside of corrections, because we know more than 70% of individuals who come in, which means that we're doing that case planning with VCCI, are on medication assisted treatment with them.
Glad to see that.
Yeah.
Because that was a major problem.
Yeah.
And there are no problems with the new healthcare agency that's doing it?
So you're asking, how is our current healthcare vendor doing now? I would ask you to ask the Department of Corrections, but my experience with this healthcare vendor is that they've done a really good job at advancing compared to that community system of care.
That's
advancing your
wonderful to
healthcare.
hear.
You will
Because-
see in the news that WellPath, who is our vendor, I
Right.
don't want to hide the ball. Remember, transparency is one of our values. That WellPath at a national level is in the process of doing a reorg of their organizations under Chapter 11, so bankruptcy. We have not seen any disruption in healthcare services here in Vermont, and we have a very strong healthcare team. And whenever we found an issue, and there have been some minor issues, whenever we found an issue, they have been willing in spades to address it and to come up with a new process to move forward.
That's wonderful. to hear.
They've been great to work with.
Well,
Oh, I'm sorry, were you,
I got another one.
okay,
You mentioned the field services director in the regional agency of human services office. Every one of them has one of these?
There are 12 district offices and there are 6 field service directors. So there is
Oh, they
one
have
field
2.
service directors per 2
Okay.
districts.
All right. I've been here 20 years. And I don't think I've ever met her. She or her. Or-
We'll fix that. If you haven't met your field service director, we'd love to make an introduction. We'd also be happy to host any of the legislators, particularly when we're doing Capital for a day, any of our legislators at our district offices to come and meet our staff.
Yeah. It would be good because we end up dealing with people that we know in there.
They're a great connection, and our field service directors, they really are there to deal with the systems related issues in our communities. And then they work very closely. I keep saying the Vermont Chronic Care Initiative. Let me explain what that is. It's a group of nurses that are all across the state who work with individuals and families who are the most complex, almost all of whom are Medicaid recipients. And they really work at that local level to address their healthcare needs and their psychosocial needs when the system's not working for them. So they often will convene community teams that include a person's primary care provider, mental health, housing provider, when the community just doesn't have anyone else who can help coordinate between that to do what we call team-based care, so that they can develop a comprehensive plan across those providers until a point at which we can identify someone who can be that quarterback going forward. And so our field service directors often will work very closely with VCCI rather than independent and to help manage an individual case, while our field service directors are dealing with the broader systems issues, like asking the question, why did that break down? Is it break down just because of a specific situation with a specific individual or family, or because something's wrong with the way that or needs to be evolved for the way that we do services in that local community? Does that make sense?
It sure does.
Yep.
And I may be wrong. Maybe the field services director, I don't know who it is, but I didn't know they were the field service director.
Yeah, and we would love to make an introduction.
Thank you.
so I had 2 questions, and the first question, I just want to say that I was asking this because I thought this is something that Daisy should have been here for. So
Okay.
Daisy may jump in and put it away, but it follows up on something Topper was talking about and something we've been thinking about a lot lately. You know, that there's this concentration right now, and the governor highlighted it in his budget address the other day around public safety. And I think for the people that sit around this room, one of the frustrations is that there's this perception that it's a mental health problem. We don't like the stigma of that. But it does beg the question. You talk about collaboration. And I think one thing that I've always been, and I think it's wonderful that we house DOC in AHS, the collaboration between DMH, DOC, and also, you know, what communication, what services, and what type of collaboration is going on between those areas, specifically with Department of Public Safety, with you know, maybe local law enforcement or with the court system, the judiciary? What is the collaboration there?
I'm going to give a few examples, and I think both Kristen and I will answer this question. Kristen will talk about the public safety enhancement teams, which really are working across the state to look at data and to work with local law enforcement and communities and to try to make the link between the Agency of Human Services and the local community public safety providers. I'm going to talk a little bit about that internal collaboration that you mentioned. And I think I'm very proud of the work that we've done following the pandemic around collaboration. I agree with you around stigma. Many of our communities often talk about mental health, and typically they really mean substance use disorder that's happening in their communities and the impact that they feel like that's having on public safety. We know that someone who has a mental health illness or has substance use is likely to be perpetrated against versus the perpetrator. But we cannot ignore that substance use disorder has had a significant impact on our communities, and particularly on people's sense of safety in our communities. And so this year, the package that we put together for substance use treatment to help fill the gaps in that system represents collaboration, unprecedented collaboration across departments. It looks at providing co-occurring care throughout the system wherever possible. And by co-occurring care, where I'm looking at mental health and substance use particularly, but we've seen a significant overlap with developmental services. But in this context, the mental health and substance use. An example is evolving the public inebriate program to make sure that that it's there as a standalone for substance use hasn't worked. So we're integrating that with the mental health crisis beds so that an individual can come in and when they are in crisis and really stabilize, even if that crisis is more substance use related than mental health. That hasn't been the way that's happened before. Those two things have been separate. And so not only does it give us a better sustainability plan, so fixing a structural issue, it's collaboration. You see that in the work that the Department for Mental Health, DOC, and the Department of Health did in looking at, well, what does it look like to make sure that we have a full continuum of substance use services so that we can ensure that we're providing treatment in the community as often as possible, but also providing the backbone supports for an individual to be successful in that. And if they're not successful in the community, making sure that that our correctional facility is also offering stabilization and treatment. And so that comprehensive substance use plan this year was a significant collaboration across those three departments that I would love to have them come in and talk with you about what the vision is around it. And that means that we're providing, as I said, substance use treatment in our correctional facilities. And in that they've been working with the judiciary and others to say, okay, if you have someone, what's the pathway in? If someone comes in and they need supervision to make sure that they're not that there's no recidivism and they're getting treatment because it's their substance use that's driving the thefts, let's make sure that we can do that in the community. If they can't do it in the community, let's make sure that there's a pathway into corrections and then a pathway back to the community and then a pathway to recovery housing so that we've got recovery options. So again, I think that represents that collaboration between departments. Kristen can talk more about I see Representative Rebecca that you have a question related to that, but Kristen can talk more about the PSET process, which is kind of more comprehensively linking law enforcement to that.
Leslie, I do see you, but
This is directly related. I appreciate the nuances of all the different pathways that you're addressing this through access to care. I just don't want to lose the importance of what's happening with messaging in so many pockets right now of Vermont around public safety and mental health, and specifically individuals who are having mental health challenges, because that messaging that's happening, I mean, I saw it the other night or afternoon, moments after a speech was given in the chamber and there was a standing ovation around getting folks off the streets. The very next statement was around mental health issues. And that's taking us back more than 50 years. Some of us have spent our entire careers to eradicate the misperception that folks with mental health issues are violent or dangerous. So I see one of your responsibilities in your role as secretary to work with the Commissioner of Mental Health to help clarify and educate the public that that is not true. And I also hope that that message is getting to our governor.
So I appreciate that. And Representative, we've been working very, very closely on that. I think that, as we've been going out, as we've been talking about communities, helping them understand that has been a core part of our visits as we're doing the public safety roundtables in each one of the communities. Being able to, for many of them, like our law enforcement, how do I help someone in crisis? I'm proud of Vermont that that's the question law enforcement is asking, not how do I lock someone up? And so I appreciate you bringing that up as an issue. We'll continue to address the stigma in Vermont.
It's happening in just one last piece, it's happening in our communities in Chittenden, local municipal leaders are saying that it is too difficult to involuntarily commit someone. So we have a really big problem with that messaging, and I just want to be sure to raise it to your attention.
Yeah, thank you. I appreciate you raising the issue.
Leslie.
So we've had conversations about this. I'm going to go to the other side of the care continuum, back to primary care. I think we all agree that primary care is crucial to moving upstream and trying to keep people healthier earlier, so we don't have to do all this, would be the idea. But we also know that there are 2 primary care practices that are closing. Well, one already closed in Bellows Falls, which is an FQHC model, and then one in Moortown or Waitsfield, whatever, up there, which is a totally different model of care, but it's still being closed. So I'm curious to understand where the conversation is happening in your department, in the whole government, in everything in Vermont about protecting primary care. And I know there's a long term ahead, whatever, but what about the short term? What do I tell my constituents in Bellows Falls who have lost their health care, and where can they look for support?
Yeah, I think that there are two issues related to that. There's a workforce issue. When we look at what's happened in Bellows Falls, and we looked at what's happened in Waitsfield, in both of those areas, there were clinics that were within 10 miles, and there were not enough physicians to fully staff those clinics. And that's not a money issue. That's actually a demographic and a people-related issue. Because of that, those clinics weren't sustainable, and we're going to have to make some concrete structural changes that are going to be very challenging to get to sustainability. We also, I was hopeful, would help us continue to advance the investments. It's now 2 years out. So I think one of the things that you saw in the governor's budget was trying to at least hold the ground in primary care. So ensuring that the payments that Medicare was making to primary care directly and on behalf of community health teams to support primary care and being able to provide whole person care, that we had to focus our dollars for primary care on ensuring that continuity. So it is a significant focus. I do think that with not enough providers and the need to consolidate them back into infrastructure, we are going to see some level of consolidation in some of those primary care practices. But we are continuing to look at how to invest in that as we go forward.
So I'm hearing you say that we could expect more primary care losses in the state.
I think that we can expect to see some of our organizations looking at how their footprint might go beyond what they can afford at this point in time.
So what do we tell our people? What do we tell our communities when we're asked? Because I'm the obvious for obvious reasons, and I'm not sure what to say because Brendan's been incredible. Thank you, Brendan. Very accessible, and I appreciated that a lot. You have been too, but that doesn't help the person who can't drive, who had been walking to their elderly, rural, poverty community. So is there a way to do it without staff? Because if there is access, you're saying, I understand we'll talk about North Star. They're up in Springfield. The idea was everyone was going to go up to Springfield, but there was no support in how to help people get to Springfield, people who can't drive, who don't have access.
Yeah.
We're seeing nothing.
Yeah.
And it's frustrating because I hear a lot, you're doing an incredible amount of work, a lot of money, but it's all end of life. I mean, it's all at the end of, it's chronic care, it's people in corrections, what about the commitment to upstream?
Yeah, I think the commitment to upstream and some of our work with the head would have been that will be a $21 per member per month addition to primary care.
That's up from 17, so it was 17.
It wasn't 17.
Oh, is it?
Oh, it's between 17 and 21,
Okay.
$21 a month.
Mhm.
That's additional resources coming into primary
But
care.
like you said, it's 2 years out.
Mhm.
So what do we do? What do I do in my community now?
Yeah.
How do we get transportation? How do we look at outside the box kind of solutions for a community like Bellows Falls or Moretown or whatever else is going to be consolidated?
Yeah, and I think we're working with communities to address those related issues. I think that that will emerge over time. Transportation is one of the things that came out in the recent report that we need to address in order to ensure access to healthcare. Our Medicaid program also provides significant amount of transportation to things like primary care visits for individuals who are enrolled in our Medicaid program. So
Yeah, I appreciate that very much. However, for my community, you have to get to Springfield via Londonderry.
Mhm.
That's not logical.
Yeah.
From a transportation point of view.
Yep, I hear you. I mean, we are investing significantly in primary care, and healthcare affordability is an issue that we're working to address, which means in some cases stabilizing some of the organizations like North Star who in order to stabilize are making hard decisions.
Yeah. Thank you, though.
Yep.
Appreciate it.
Thank you. Any other questions? Great. Thank you for coming in. I apologize for the scheduling mix-up the other day, so thank you for being flexible.
We appreciate being here, and we are available if you have any other additional questions or recommendations.
Thank you. So we're going to hear from Department of Mental Health now. Are we leaving them? Yes, it is, but I like it. Okay. This is a meeting. I thought I prefer more of
Yeah, that's good. Thank you. Because I did want to see it from the beginning.
Yeah, that's.
And you trash this room, could you bigger, right? Hello.
Hello.
Welcome back.
Sorry, I made such an entrance over here earlier.
I know.
We had some. One. Yeah.
Sure, Amy's got some. Thank you.
I'm not a stickler type person.
Whoa.
I'm getting all sorts of stickers today.
I know, I love those. Robin.
Can I make a comment?
Of course you may.
I'd just like to praise Commissioner Hawes. Last summer,
Last summer, okay.
last summer, I called you regarding an individual who was having issues with their spouse. And you were very gracious. You took my call. You listened to the situation. I gave you the information. And as far as I know, you talked to that individual and you helped that individual. And I just want to let everyone know that when you have a situation like that, you can call the department. No, I'm being serious.
Yeah, thank you.
Very nice of you to, I'm just another legislator here. But when I do need assistance for a friend or a constituent, your office is always available and you take the call. And
Thank
for
you.
that, thankful.
Yeah, thank you.
I'm done.
Should we wrap it up then? Just give me one opportunity, just because I forget that I can't see the event, so I'm just gonna log into the Zoom meeting real quick. Maybe. Okay, great. Thank you. All right, good morning, for the record. Good
afternoon.
Oh, my God. Oh, dear. You blame Amy Johnson. Good afternoon. For the record, Emily Hawes, Commissioner for the Department of Mental Health.
Laurel Oland, Director of the Child Adolescent Family Unit at the Department of Mental Health.
And then online for us joining via Zoom is Deputy Samantha Sweet and Kristen, Bates, our mental health services director for the department. All right, and so I think Claire, you're going to run the show today. Great, excellent. Great. So we'll be providing a mental health, Department of Mental Health 101 for folks today. I'm aware we have a mixture of folks who are new to our mental health system and who have some lengthy experience, whether providing service or within this committee. So we'll go through the high level. We're going to spend some time getting into youth and kids specific information with Laurel. And then we can certainly come back for future dialogue if there's follow-up questions. Great. So as you see, the Department of Mental Health, our mission is to promote and improve the health of Vermonters. So the department resides under the Agency of Human Services, has the same critical mission as the Agency of Human Services, which is to improve the conditions and well-being of Vermonters and protect those who cannot protect themselves. Our vision is that mental health will be a cornerstone of health in Vermont, that people will live in caring communities with compassion for and a determination to respond effectively and respectively to the mental health needs of all citizens. Vermonters will have access to effective prevention, early intervention, and mental health treatment and supports as needed to live, work, learn, and participate fully in their communities. So who are we? So we are responsible through statute for the mental health system of care for all Vermonters. What that means from a Department of Mental Health lens is that we're composed of 302 staff. That includes 2 facilities, the Vermont Psychiatric Care Hospital and the River Valley Therapeutic Community Residence, as well as our central office staff, which hovers around 70. DMH handles a budget of around 326 million. As you can see in this breakout, that 326 million serves approximately 25,000 Vermonters. We oversee 10 designated agencies.
and 2 specialized service agencies. And we're going to talk a little bit more about what that means later in the show. We also, like I said, run the Vermont Psychiatric Care Hospital, which is a 25-bed hospital located in Berlin for adults who are all under the care and custody of the Commissioner for the Department of Mental Health. So what that means is that folks have been placed there involuntarily. We also,
Go ahead, Woody.
Regarding the psychiatric hospital,
yes,
it's closing though eventually, is that correct?
no.
It's not the one that's closing.
There is a unit at Central Vermont Medical Center, a 15-bed adult inpatient unit that is set to close. Is tomorrow the 30th, at the end of this month. VPCH is in statute that came from Act 79 after Tropical Storm Irene, and we operate at 25 beds with a waiver from the federal government. That waiver does expire. I think in 2027 or 2029. 2027, is that right? Great. And the legislation from Act 79 requires VPCH then to transition into a 16-bed facility in order to continue drawing down Medicaid and Medicare funding. That's what is currently in legislation, and so we'll need to
So you're working.
address that. Yes.
Yeah.
Our goal would be to keep it at a 25-bed facility and serve the folks that they've been serving well. You're welcome.
What is the census there right now? I know that at one point it had been almost at 16, right?
Yes, it is at 21.
Okay.
That hospital has 4 units. So 3 of the units are online right now. There's enough staffing mix there for those 3 units. That's up to 21. With plans in place to be back up to 25, hopefully by the beginning of July. But that's a very aggressive timeline to get up to 25. It requires, hiring more permanent staff. So, but we have set some things in motion that we think can help with our recruitment and retention there. Great. River Valley Therapeutic Community Residence is our other facility. And that is a 16-bed facility, which is a step-down facility. So individuals who no longer need a hospital setting, but still benefit from a secure setting in order to continue meeting their therapeutic needs. That is located in Essex. And they have 12 folks there right now with plans to take 2 more here in the next I think the next 6 to 8 weeks, and then the 2 more onto that. They're in a similar situation as VPCH in that we're balancing how many contracted travel partners are providing care and bringing in more new staff and not bringing in as many traveling staff so that we can serve folks in the safest, most appropriate way. But B, it's very expensive to contract with travel nurses. Next, we have several contracts and grants to peer organizations. We hold the contracts for the forensic psychiatrists. We also do grants with psychiatric consultation and primary care. If folks aren't aware, we have a grant from the federal government for SOSVT, which is a flood response case management service that we provide. And then we also are working with the community roundtable contract to conduct analysis of population level data related to mental health. And then we also partner with all of our hospitals, all community providers, housing specialists, police department, sheriff's departments, courts, pretty much anyone that you can think of as a community partner, we are collaborating closely with. We operate under a framework of 4 key areas, and that is someone to prevent. And so I believe that Chris Allen was in here this morning, our director of suicide prevention. So our suicide prevention work falls under the someone to prevent. as well as responsible gaming. And then the next is someone to call. We want folks, our community members, someone whom they can call. And there is somebody to answer the phone. That's the 988 Suicide and Crisis Prevention Lifeline. We also have a Pathways warm line. There's a peer run warm line, as well as those individuals who need additional supports related to the flood response. Then someone to respond. I think Secretary Samuelson probably talked a little bit about enhanced mobile crisis response. That's our two-person response, 24/7, meeting folks out into the community, as well as including persons with lived experience, credentialed peer support specialists. Our designated agencies and specialized services are someone to respond. And then somewhere to go, excuse me, such as your hospital level of care, your residential level of care, our mental health urgent care system that we've incorporated into our broader system, our children's residential system, and our micro residential system. Let's sit here for a second. This is a snapshot of what our overall system kind of looks like when you put the layers of care together. And so starting at the bottom, which, like a pyramid, you want your bottom levels to be your most stable. And so starting at the bottom with our community mental health system, from a bed perspective, it's around 191 beds. That also has FIF housing vouchers for individuals to take advantage of. That includes a package of service with that housing assistance. That's also where you find your traditional individual, family, group counseling services, all of your school supports are within that section. So those are your foundation of services that are supporting your communities. The next level up is our crisis supports and response. From a bed perspective, you heard Secretary Samuelson mention this in her testimony. We have crisis beds for adults, we have crisis beds for children. We also have our 988 and enhanced mobile crisis response and our mental health urgent cares. This has been a level of care that we have really targeted the past several sessions to enhance getting care to folks in their communities when they most need it.
Can I interject there real quick?
Absolutely.
We heard about that earlier today, and we have how many? 6 urgent care facilities at this point? 6 or 7, was it?
Yes.
Is there plans to expand that to other parts of the state?
Yeah, so we'll go into those urgent cares here a little bit later in the slide and in the show. And I will say one great thing about we have very different types of urgent cares throughout our state. And so being able to determine what types of urgent care are utilized and what those communities' needs have given us an opportunity to get data collection and understand what type we would like to expand, where we would like to expand. So we'll get to those, but most of those have just come online in the last year.
Did you have a question?
Can you differentiate between youth residential PNMI and youth group homes PNMI?
That's a really great question that I'm going to have Laurel answer.
PNMI is an acronym. It means private non-medical institution, and it's a category under Medicaid. And so those are rate set by the Division of Rate Setting. All of the placing agency departments are part of that review of the rates. So Department of Mental Health, Department for Children and Families, and Developmental Disability Services are part of that process. Typically, a PNMI program is a residential program for children, and often they have a school associated with that, or at least a tutoring program. The group homes that you have listed on here, some of those might also be PNMI rate set. Some of them might not be. They might be part of the case rate for the designated agency or specialized service agency who provides the service. Those do not have schools affiliated. They are much more embedded within the community, and those youth go to a local school, whether it's the public school or an alternative therapeutic school. And the programs really try to get them out and doing other community type of activities. So it is still a residential setting that's therapeutic, but it's, I would just define it as more embedded within the community.
Versus the youth residential, which is,
Those are the PNMIs. I believe that's what's on
they
there.
both say PNMI.
Some of them could both be PNMI rate set. That's really a Medicaid terminology, so.
Yeah, I'm less concerned with the PNMI. I'm just wondering, they're at two different levels. So
Yeah, I
how do
think-
the services differ at those two different?
I think it's about how immersed within the community are they, and then whether it's a more intensive kind of contained residential setting.
Is it safe to say that one encompasses in-house education and schooling, and the other youth leave for the day to go to school and then come home back to the residential? Is that
Yeah.
safe to say?
Sure.
Okay. Next level of care is our intensive residential, which we've talked a little bit about our PNMI or youth residential structure. We also have intensive residential programs for adults, 5 of those. We also have a peer-run residential. And then last legislative session, we did some work in this committee and others developing a youth psychiatric residential treatment facility. And that is currently in contract.
When was the timeline for that opening? Oh, is that your?
It's close, that contract's about done. So I would, initially it was this past November. So it's could be hopefully in the next quarter, within the next quarter.
Okay. Remind me, that's the one in Brattleboro.
Correct.
Lori, I'm sorry, Lori, was
That's
that
my
your question? Okay. Leslie?
A quick question about this. We got one of these last year. Is this
Yeah.
the same?
Or it's been
It's ever-
updated.
I need to put the new one.
Yeah, so this is a new one. Where the updates are going to be likely around some of the mental health urgent cares. The PRTF is newish into there. We probably put it in at the end of last session. And then the shifts at the inpatient level, which is our top tier, your most expensive, highest level of care that the state offers. And so there are around 215 beds, and that's a mixture of adults and youth. From a children and adolescent perspective, we currently have one facility who offers care for hospital level of care, and that's the Brattleboro Retreat. And we have a pending CON for an additional unit at SVMC in Bennington.
Does this include the 215? Does that include Central Vermont?
No, we have taken Central Vermont out. So Central Vermont was a loss of 15 beds for the system. Most recently, they have been at around 8 because they have one psychiatrist, and one psychiatrist caseload for an inpatient unit is usually around 8 hospitalized individuals. So Central Vermont Medical Center is on tap to close that unit the 31st of January. And so that is reflected in these numbers. We have 6 facilities across our state that offer general inpatient level psychiatry care. And then we have 3 facilities that provide additional services in inpatient psychiatry called Level 1 unit, which is Level 1 came out of Act 79 as a way to identify units that individuals hospitalized there need additional resources throughout their stay. So very similar to those individuals who were admitted at the Vermont State Hospital before Tropical Storm Irene. We have 3 facilities that do operate, and that's 57 beds. Great. So now that you have seen our wonderful system, let's talk about what it takes to staff that system. Because we all know that we've been in quite a workforce challenge for the last several years, certainly exploited by our pandemic. So Vermont experiences what nationally healthcare and specifically mental health and substance use providers experience, in that we have a shortage. And that while we have an increase in demand. And so meeting an increased demand with a shortage has been what we've been focused on for the past several years, and we will be focused on into the future. As you can see from this slide, as we move towards the next decade, the demand will continue to increase and our supply of workers will continue to decrease. And so I'm going to let that rest for a second while I go in and talk a little bit about staffing at our facilities and across our system. When it comes to DMH facilities, the Vermont Psychiatric Care Hospital, River Valley, and Central Office, we've made some gains. So a year ago, as a department, we had about almost a 40% overall vacancy rate, with BPCH at 50% vacancies, River Valley at 42%, and then Central Office at 12%. In the last year, that has dropped. To me, that's a significant drop, but to others, it's not enough. We still have a lot of work to do, but today we're hovering at around 32% overall vacancy for the department, 35% at River Valley, 42% at the hospital, and then 5% at Central Office.
At River Valley, the hospital, are you relying on travelers?
Travelers do supplement some of those vacancies. We also are managing it through bed availability, which is not unlike the rest of the system in that. So, for example, BPCH is at 21 beds. And that is because we have enough staff to balance 21 beds. And there are travel partners in that mix of staff. But we don't want to bring on all more travelers to get to 25 beds. There is a risk from a safety perspective of too many travelers versus permanent staff. And so that's how we manage it. Yes, there are more. Yes, there are travelers mixed in there. This was also the first year we haven't had to adjust our budget to make up for our travel partners and the costs related to that. So we're seeing some positive impacts related to hiring. We've seen more applications in the last 3 months than we've seen in the last 3 years. And so we feel excited about that. So we're going to keep writing on that. From a full system landscape, let's look at our designated agency and special service agency vacancy numbers. And you will see back prior to the pandemic, vacancies hovering around 400, 470, certainly skyrocketed throughout the end of pandemic. And we are starting to see those come down. In this slide, you'll see that it's pay increases were instituted at several of the agencies due to the crisis level staffing issues. And those increases happened around December 21 through September 22. And then in July of 2022, there was an 8% rate increase. So we are seeing those vacancies come down. I think it's also taking a look at how do we efficiently deliver care. And I think that there's some creative and interesting ways to look at that. Secretary Samuelson mentioned the public inebriate and the crisis beds. Very similarly skilled individuals who provide those services. The public inebriate bed is essentially as an on-call. somebody needs this service and you have to staff it regardless of whether or not somebody needs it. As we look at our mental health crisis beds with similarly staffed units, not units, but similarly staffed beds, how can we look at the efficiency and is there an opportunity to combine that bed, so to speak, based on whoever needs it, who is ever at the door? And so those are the conversations we're going to talk about as we move through the agenda for the governor's initiatives. But that is certainly an area where we saw these are similarly skilled clinicians. And when you have competing human service positions in a workforce shortage, we need to be looking at those and make sure that we're training and giving adequate skill sets to the folks so that we can serve whoever's coming. The next couple of slides are investments that have been made in specific to the designated agency and specialized service agency workforce. So I'll highlight these have started June 2021. The task force was launched. That's a collaborative task force, really looking at what options we have for recruitment and retention. There was immediate workforce stabilization funding in December of 21. Which included $2 million allocated by the AHS Secretary's Office for retention efforts. $15 million request to CMS for recruitment training. And then 2022 session also included investments into workforce retention and recruitment. You'll see as we go through March 2022 through the fall of 2024, which is our most recent data, is another 550,000 from the HCBS FMAP. Can we go back there just for 1 second? Let folks pause, read through that, and happy to answer any questions if you have any.
I had one on the previous slide.
Yeah, great.
The 2021 15 million request for recruitment training infrastructure improvements. Was that CRF or COVID relief dollars?
Good question. I don't think so. I don't think so, but Cheryl Wilcox was our lead for that, and we can get that to you.
It was stabilization funding. I'm just curious.
I'm thinking as you're saying.
I'll try to find it.
It might have been ARPA. Anyway, Cheryl is our lead on that, and we can get those specifics back to you.
Actually, could you talk about this slide that we're reading, which is the next one? The 4 million for improved safety and accessibility. It says completed in 24. How's that? Has it helped?
Yes, so those targeted buildings needing to make improvements for access for folks who may need a wheelchair or have some assistance in that way. And those grants all went out, and that did provide much needed supports from a facilities perspective. And that was the parameter of those particular funds.
Forgotten about those.
Yeah.
Yeah, go ahead.
Just real quickly, are you gathering any data as you do these workforce recruitment efforts and things like that? I know you've done quite a lot of investing in workforce initiatives since 2020.
Yeah, so there's data that we get that we just showed related to the vacancy rates. We have Cheryl collects data in the work that she's doing with the workforce groups. I guess it depends on what kind of data you're thinking about.
I'm looking at effectiveness of some of these investments. I know for a while we were doing bonuses, like retention bonuses and hiring bonuses, and I've just never seen data that those are really impactful.
Oh, okay.
If there's data that they are here, that would just be great. I'm just
Yeah.
curious to see.
That's a great question. We do know that retention bonuses, the loan repayment options that folks took advantage of. Retention sign-on, there were sign-on opportunities for folks. We do know that those positively affected hiring. So whether, I'm sure we have some data somewhere about that, so let me just
Wonderful to
see.
see,
Yeah.
like how long they stay.
Yeah, we might not have that, like how long somebody stayed unless there was parameters around someone's retention or retention bonus. Sometimes it required somebody to stay 6 months and maybe they left 6 months and 1 day later. I don't know if we'll have like into that much detail, but we probably have a general sense of what worked and what didn't work. Yeah,
Do you mind if I?
yes.
So for the record, Nicole Stasio, the Director of Policy for the Department of Mental Health. I can send you the data, but there was a 96% effective rate. I remember it because it was such a high number. And we had actually talked to the folks who had stayed and said, like, was this a contributing factor to the reason why you stayed? And the majority of them said that it was. So I'll find you, that data is a little bit old, so I want to see if it's still, it remains that high, so I'll get you some updated data, but it has, I think it's one of the programs that we can actually point to as having a real outcome that we can show.
That'd be nice to see some numbers,
Yeah.
because when you look nationally, there's research shows that there's really no evidence base behind those approaches.
Oh, yeah, I'll get it for you, no, not, it's no.
Getting data around retention, I was hoping that you could get data on if new hires stay for a length of time, what is the probability that they will end up staying? I'd kind of like to know.
That's I said, that's a really good question. I'm not sure if we have that, but I'll look.
Something to know internally for state government is our partners at the Human Resources Department likely have a lot of data related to state of Vermont employees because they host all of our recruitment data. So something to consider if you're interested in what could be working or not working from a state employee lens. Yeah, okay. Let's move into our crisis system of care. So I want to preface that this is a vision. This vision could come to reality in 15 years. It could come to a reality next year. But a lot of folks see this slide and get nervous. So I'm just going to start with that. And part of that is we have a really wonderful program with our Vermont State Police with individuals who are embedded as a co-response. And that is a crisis service that has been really beneficial to Vermonters. And so sometimes that group of folks are confused when we talk about the crisis system for those embedded workers at the state police specifically. So from our vision for the crisis system is that a human is in crisis and they pick up the phone and they're going to call 988. Currently, about 95% of the calls to 988 are resolved on the phone. And the person goes on, maybe they call at a later date when they are having a hard time again, but a 95% resolution on the phone is so impactful in our communities. The next thing is that if you do need somebody to respond to you, we have our 2-person enhanced mobile crisis response. So you are on the phone with 988. It's decided that you need an intervention right then that's not via phone. 2-person response can come out and see you in the community. 81% of those are resolved at that time. And then the next step, let's say you need the enhanced mobile crisis response doesn't resolve what's happening for an individual, you can then go to an alternative to an emergency department. You can be there, have an intervention, you can stay up to 23 hours. And perhaps that resolves. If that doesn't resolve, then there's an opportunity to go to a crisis bed where you stay the night or a few nights, crisis resolved, and move on. That doesn't take away that there's not going to be a need for a hospital level of care. Folks are always going to probably have an option for a hospital level of care. But what we would like to see is that our local law enforcement, emergency medical, first responders aren't having they can do the things that they were designed to do. And that our community members can utilize this crisis system to get their mental health and substance use treatment and interventions in that point in time. What's different about this crisis system is that it's co-occurring. So individuals can be experiencing a mental health or substance use crisis that is different than historical delivery of care in our crisis system. It also is a really nice complement to the work that happens across our police, sheriff, EMS, and first responder system. And having all of those folks collaborate together with the individual who may need support in getting to the right level or place for their supports is what we envision for Vermont.
Can I interrupt one moment? Just want to put this out there for anyone who's listening or in the room, because I think this is really important. We're going to continue this until and we do have to get to the floor because we have to support a member on the floor. And we're going to vote on H31 after the floor today. So heads up. Okay, Topper, I'm sorry.
It's fine. Commissioner, or is it secretary?
No, not secretary.
I hear what you're saying, and I read in the newspapers and I see on TV a crisis taking place and people getting killed. And I'm wondering, what's the connection? How do you get involved? Because I would think that, anyway, if you can answer that question, did they call you up? I know people are embedded. State police go out and the next thing you know, an officer is on administrative leave because somebody was shot.
How we envision it working is that if there's an individual who's in crisis, they need support, they can call 988.
Okay.
Just like you would 911. You call 988 and we're working actually with our 911 dispatchers
Right.
so that they can also dispatch through 988 our enhanced mobile crisis response.
Yeah. And if the incident is ongoing, they're probably not going to call 988. Do you get involved in that?
I think that's a hard question to answer because I don't know if I'm following the question.
Okay.
So what I think you're asking is, let's say something is terrible has happened. Where does the mental health system interact with either somebody who is involved, whether they're law enforcement, whether they're somebody who is in crisis or a victim of some challenge? Where does DMH get involved in that? Is that the question? Or how?
If I'm a person, let's say it started out as a domestic dispute or something, and police were called, and then they realized this is more than that. Do they call you and ask you to
Sure,
come on the scene with
Yeah,
them?
they can. We have some police departments who have embedded police social workers. But they can call 988 and have somebody respond once the scene is safe. That's certainly an option for folks.
Because I read a lot and hear a lot in the newspapers.
Yeah. I get that. And I also want to make a plug that, people who are experiencing mental health and substance challenges are more often a victim of crime and violence, not the perpetrator. And so it's really important not to kind of mix all that up together as one event that is where people are dead at the end. Right? That's going to purposefully evoke the highest intense emotions as a reader that you can have. So there's always a lot to every story.
Yeah.
And we're going to collaborate with our friends at Public Safety as much as we are able to. We have very good relationship with them. We don't want folks to get hurt. We also know from research that individuals experiencing a mental health and substance use crisis are in danger when there's a law enforcement response. We've seen that. The state has put together a committee that looks at that. And I think we've done really good work as a result of taking a look at how to increase and enhance training across our first responder system. I think we've done a really good job with that.
Thank you.
Yeah.
Can I just do a clarifying question? Oh,
Yes, go ahead.
I'm sorry. I'm just kidding.
That's all right.
Okay. So because not a lot of people know about 988.
Yeah.
If somebody were to call 911, you said there's embedded.
Yeah, we're working with our friends at the 911 dispatch. And this is a national challenge. And 911 is not that old. It seems like it's old, but it's not that old, relatively speaking. And certainly 988 is not that old. But so we are working to streamline the dispatch in the connection between 911 and 988. And callers should call whatever number they think of, right? We're going to work on a system that gets you the services you need. It shouldn't be up to you or me in a moment to remember, like, what number must you just call the number? Call the 3-digit number. Our preference, of course, is 988.
And one more little question that has to do with it is, so I think that community police officers become very attuned to who calls a lot. I have a very good friend who's police, and she always said, they come with these body armor things, and she said, if someone just come and help me, because he's a big boy and she's afraid for both of them. Do they know at that point, we train the police officers that this is someone who calls often and we know how to handle this and will automatically send somebody from mental health?
I wouldn't say automatically, but I also heard some testimony earlier from Secretary Samuelson about the PSET, the Public Safety Enhancement Team, which gets all of the entities at the table in order to have a conversation about how to streamline conversations and resources so that there is enhanced training and knowledge about who to call in what situation. Some situations are going to happen and you're like, oh, I don't know who to call.
Yeah.
But you have the resources in front of you and for that response. And I think we also want the person in crisis to be safe. We want the responders to be safe. And doing that in a collaborative way serves everyone well.
Thank you.
Yeah.
I think we've got at least another 5 to 10 minutes. Okay. I just want to ensure that everybody's on the floor.
That's fine. We can also come back at another time. Let's take a breath.
Why don't we finish with 988?
Great.
Because I think you have a couple more slides on
We
it.
do. We have a couple slides around 988. And so we've talked a lot about 988. I like to take 988 stickers with me wherever I go. Magnets. Right now I'm targeting restrooms and restaurants. I try to put them wherever I can. So I highly encourage that because people should know that resource is there. This resource is currently being staffed by 2 designated agencies that we contract with, Northeast Kingdom Human Services and Northwestern Counseling Services up in St. Albans. And they answer just about 90% of the calls. We have seen an increase in call volume over the last couple of months. And so we're working to make sure that we have enough resources to answer the phone. It's always answered. I want to make that clear. It's not going to go to voicemail. It is always answered by someone. And for the most part, that someone is sitting in Vermont. If nobody in Vermont can answer the phone, it kicks over to New Hampshire. And we have a contract with a New Hampshire resource that will then answer it. Nobody's available in New Hampshire, then it picks up to the national line. But for the most part, that 988 is being answered by folks here. Like I said, we are experiencing an increase in calls. So for the month of September, we had a 93% answer rate. Don't get confused. It just means that the 93% were answered by individuals in Vermont. The other calls were answered, but it just kicked over to New Hampshire or the national. And you've seen that steadily increase. We think and hope part of that is due to folks hearing about 988 and talking about it and feeling comfortable calling the number. You'll also see that the answer rate starts to decline when it gets, when it got up to around that 1,400. That could be a staff vacancy at one of the agencies. And so it kicked over that maybe a shift wasn't covered. And so it kicked over to New Hampshire, but that is something that we're keeping a really close eye. Leslie?
Do you keep any data on if a call is answered outside of Vermont on the outcome of that call?
All data for 988 calls is kept within the Vibrant Exchange program. So we have a contract with them to track as much data as possible. I can have Jeremy Tarian come in and talk about the 988 data. If that would be helpful at a later date. I'm not prepared to talk to that now.
I totally get it.
Yeah.
But I'm just seeing that, I'm just wanting to know that with the drop in the Vermont rate, are people getting the services they need?
They still
And that's
are,
my
yeah.
question.
They still are. They're still talking to somebody and 90% of those are still being resolved on the phone.
And they're being referred to places in Vermont.
If they need to be, yeah. Some people are calling because they're just having a hard time in that moment and they don't need a referral of anybody. Okay. Les?
Yeah.
I have a question.
Quick one. 73.6.
Yeah.
That says to me that over 25% of the calls now are not being answered by Vermont people. Does that cause for concern at all? I mean, is this help that's needed or why is that happening?
Yeah, well, I want to make sure that the call is answered.
Right.
I think there could be some nuances there. You could have, somebody who is working at one of the agencies. Maybe there's an open position there. Also, the call volume has gone up by 500 calls.
Yeah.
So we are we don't want it to drop. We want to figure out how to staff those positions, staff those calls so that we keep that high answer rate. Our 90% answer rate is much higher, I think, than the national average for those in-state responses. But Jeremy is our content expert on that. And so I know that he would welcome an opportunity to talk about it.
Not only that, the amount of time you have to wait to get an answer. If you're in a crisis and you're
Yeah,
talking.
because they pick up within 2 seconds, I think is what it is. Yeah.
According to that, 20 seconds to 37. The 20 seconds is the goal.
I think we're missing a decimal. I think we're missing a decimal. No, it's much shorter than that.
I think he indicated it was 3 seconds earlier.
I think we're
I think
missing
that's
that.
3.7.
It might be 3.7, yeah.
I was gonna say,
Topper, I'm sorry, excuse me. If
If
it's just 37 seconds, we're not doing it right.
that's what.
You need to be yelling at us if it's taking.
Okay.
To answer that.
Thank you.
Yeah,
All right.
we'll double check it though,
So we'll have you come back.
please.
Progress. I did want to say, I think I remember from last year, don't we always traditionally have a bump in November, December, January?
We do have, traffic for, call for during the holidays
Yeah.
do increase.
Every time I see it, I think holidays.
Holidays, but also we know that more people are comfortable reaching out. We also know there's a lot going on in the world that is causing an immense amount of stress for folks. And so we want those call numbers to be that high all the time. We can.
Great, thank you for coming in. Thank you.
Thank you for everything you do.
Yes, thank you for the great work you do. It's not just Woody who thinks that. To the committee, make sure you're on the floor by 3:00. Be there to support Penny, and we will come back to the committee room immediately after the floor. So, follow the gavel. Okay?
Good.
Okay.
Penny, you know.